I'm going to take my mic off.
Apologize. There we go. Okay. Is that come through?
Yes, that's fine.
Okay, brilliant. Okay, so hi everyone. So my name is Vicky and I am Deputy Lead Scientist at Great Ormond Street Hospital for Children in London. And I am what we call a healthcare scientist, and that's what I'm going to talk about a bit today. So I'll do a little bit of background on my career, and then I will talk about healthcare scientists and what we do within the NHS. And then I will talk a little bit about SARS-CoV-2 and the COVID-19 outbreak, because my background is as a virologist, and there's an awful lot of misinformation flying around at the moment, so I can give you a little bit of clarity on that one. And then there'll be lots of time for questions if you want to ask questions, because I don't want to just talk at my own laptop for an hour. So, firstly, so what is healthcare science? Because it's an area of the NHS that I'm sure most people haven't heard of. So we use science, technology, engineering, maths, and computers, so it's all of your STEM subjects, to diagnose, treat, and prevent disease and injury in patients. So that's quite a wide area. We are a very small part of the NHS workforce, so we're only 5% nationally, which is only, so 1 in 20 people who work for the NHS are scientists, but we are responsible for 80% of the diagnoses made on the NHS. So that is huge. Like 4 out of 5 times that you go to the doctor, it will be down to a scientist who actually does the work for them and tells them what you've got. So we are just that good. We carry out as a group over 1 billion tests and examinations every year. And years like this year, that number will be down slightly because a lot of areas of healthcare have been closed. But there's also increase in certain things like the sort of COVID-19 testing. We have over 50 specialisms. So what I really love about healthcare science as an area is that if you want to work in healthcare and you're into science, we will have a specialism that works for you. So we have 4 major areas. We have life sciences, physiological sciences, medical physics and clinical engineering, and bioinformatics. So life sciences. So I'm a life scientist, so I actually specialize in 2 areas. I specialize in virology and in immunology. So I used to study viruses and looking at whether or not people are infected and what they're infected with, and then testing, monitoring people who have been infected with chronic viruses, so something like HIV that you can't cure. And then we would look at, there are certain viruses so that everybody is infected with, but they're only dangerous in people who are immunosuppressed, something like Epstein-Barr virus, or which is known more colloquially as kissing disease. I also look at the immune system, so that looks at sort of allergy, autoimmune diseases, which is where your immune system attacks itself, so something like lupus, and people who are immunodeficient, so their immune system doesn't work the way it should. We also have hematology, where you look at blood, and biochemistry, which is where you look at elements in the blood, and various others. Scientists within the life sciences, these are what you would normally think of as a scientist. So you're white coat wearing, working in a lab, you don't really see patients, dealing a lot with sort of blood samples and other body samples. It's an area for people who are very into biology and chemistry. And so degrees would be things like biochemistry and biomedical sciences, something along those lines. Our physiological sciences, so these are people who work with organ systems. And these are often people who work directly with patients. So audiologists will work and they will test for hearing, they will fit hearing aids. If you have particular types of deafness and you have what we call a cochlear implant, they will follow that up and they will look after you post-surgery. We have people who analyze sleep, people who work in cardiac science and vascular science. 40% of deaths in the UK currently are down to cardiovascular disease in some way, shape or form. And so cardiac physiology and vascular science is an area where there is a huge amount of vacancies and will continue to be. So if you want job security, that is a really good one to go into. It's an area for people who want to work one-on-one with patients, quite often people who want to see the same patients. So our scientific director, so our head scientist for all of London, is an audiologist, and she only finished seeing clinic patients in the last 6 months. And in her last month as an audiologist, she was still seeing patients she had first seen 36 years ago, which I think is really nice. It's the biggest degrees people do for this, the physiology. Sports science is a huge one. It's an area that a lot of people who do sports science at university go into. For people who are more into maths and physics, we have medical physics and clinical engineering. So if you have any form of radiotherapy within the NHS, that is designed by a medical physicist. They do radiation safety. They organize and process and then analyze CAT scans, MRI scans, anything that's looking inside the body. And then clinical engineering. So every piece of equipment within the NHS has to be monitored. It has to be looked after. It has to be maintained. And we have huge engineering departments to do that. But they also have engineering departments that look to develop new equipment. So I have a colleague in Cambridge, and she is designing a new type of ventilator. I know engineers who design prosthetics, so they will design new legs for people who've had them amputated. So there's a lot of scope within engineering if people want to do something that's new and on the cutting edge of science. It's very physics and maths based. This is for people who really want to get involved in the sort of harder science, more sort of serious physical sciences. And then we have bioinformatics, which is not a word I will have expected any of you to have heard. So what bioinformatics means in essence is use of large data sets. So the big area here is genomics. And this is what, at the moment, personalized medicine is becoming a huge part of the NHS. So they've recently completed something called the 100,000 Genomes Project, where we've sequenced 100,000 genomes, human genomes of people who had rare diseases or cancer, and used that information to monitor their treatment and actually discover what was wrong at a DNA level. So you had people who had similar symptoms, but actually had very different medical conditions. And it's done a huge amount of work, and it's massively increased what we understand about so much disease. And in the future, this is where medicine is going. It is also the only area of healthcare science where you can make big money. So there's some people who come out, if you come out of university with a bioinformatics degree, you will be in high demand. And there are places where people can earn 65,000 straight out of university. And this is the only area of healthcare where you will ever manage that. It is a computing-based career path. It's very good for people who are interested in designing software and programs and data, statistics, and a whole bunch of things, I'll be honest, I really don't understand. So the other thing that's really great about healthcare science as a career path is you can enter at almost every level. So we take on apprentices. So I am a lead assessor for apprentices at levels 2 and 4, which are people who enter age 16 with GCSEs, and they go for healthcare science assistant posts where they get paid and they do a diploma at a local college. People who enter with A levels, who will then do a level 4 or 6 apprenticeship, which means they will get fully funded and paid through either a foundation degree or an undergraduate degree. This is how I got into the profession. So I've been in the NHS since I was 18. I have 3 degrees. I have started my 4th, and I will be starting my 5th, which will be my PhD next year. And I have this much student loan. I owe not a penny back. And believe me, that is an unusual thing to be able to say. So we also have people who enter with an undergraduate degree, so they go off to university, and then they can come straight into the NHS afterwards. And then if they do, we have a scientist training program, which allows people to do a master's while they're working, or biomedical scientist training, which is where you can register as a biomedical scientist and work in a lab doing on-the-job training. So there's so many options. We are a highly qualified workforce. So while you can enter at age 16 with just GCSEs, 1 in 8 healthcare scientists holds a doctorate, so is PhD level. 1 in 2 holds a master's degree. And there is always room for support and development that way. We are now at the stage in the last few years where scientists will sit the same exams as doctors, and you can actually now apply for consultant posts. So exactly the same post that medical consultants sit, which is really good. So we're finally getting parity within the health service. So I'm just going to talk a little bit about COVID-19. I'm sure you're all as fed up of it as I am, but I think it's really important just to talk a little bit about facts around COVID-19. And as there's a huge amount of information out there, and some of it is quite alarmist, so it's making people more scared than they need to be, and some of it is downplaying the risk, which can be just as dangerous on the other way. So the first thing is, what is a coronavirus? So you'll have probably heard people throwing around the words COVID and COVID-19 and coronavirus. So a coronavirus is a group of viruses, and it's what we call an upper respiratory tract infection, which means it infects the upper part of your throat and lungs. But it will get in through the upper part of your throat if you breathe it in. General symptoms are cough, headache, sore throat, fever, runny nose, spread by coughs and sneezes between people and coughs and sneezes that land on contaminated surfaces. This probably sounds to you like a common cold, and that's because most of coronavirus, that's what it is. If you have a cold in the winter and it's got a bit of a cough that lasts for quite a while, chances are it's a coronavirus. So most of you have probably had a coronavirus. Almost everyone has, almost all of them are relatively mild, but there is some history of coronaviruses that have become quite serious. So back in 2003, there was an outbreak of coronavirus called SARS, which stands for Severe Acute Respiratory Syndrome. And that had a really high death rate. So 1 in 3 people who caught SARS died, and it killed about 800 people in China. And then there was the Middle Eastern Respiratory Syndrome about 10 years later, which again killed about 1 in 3 people in the Middle East who had it, and there were about 800 deaths. What we had at the end of last year is on the 31st of December, China reported their first case of a new virus, which was called SARS-CoV-2. So this is the follow-up virus to the coronavirus that caused the SARS outbreak back in 2003. So it stands for Severe Acute Respiratory Syndrome Coronavirus 2, and that is the name of the virus. COVID-19 is the name of the disease. So it causes this disease. COVID-19 is because it was first reported in 2019, not because there were 18 types of virus before it. We had our first case reported in the UK on the 31st of January 2020. That was almost certainly not the first case that actually turned up, but it's the first one that we know of. The World Health Organization declared a pandemic on the 11th of March 2020. Now, a pandemic is any outbreak of infectious disease that has what we call sustained transmission, which means that lots of people are routinely infecting others within a country. So it's not that people are flying in and infected people are flying into a country and you get cases that way, but it is transmitting within your local community, and that's happening over a good portion of the globe. We don't declare pandemics very often. The last one was in 2009 with influenza, which was known as swine flu. There have, as of today, been over 13 million cases worldwide of COVID-19 and 585,000 deaths. To put that into perspective, globally, there are normally between 250,000 and 500,000 flu virus deaths every year. So we have already had more deaths than we would expect from flu, and that is with almost every country imposing a lockdown. So this is far more serious than flu. Coronavirus is not a flu virus. There are strong differences between the two. Unfortunately, if coronavirus is almost always negative, so we have treatment for flu. We do not have a treatment for coronavirus. We have a vaccine for flu. We do not have a vaccine for coronavirus. We have, and the death rate is about 10 times what it would be in flu. We've recorded cases in over 180 countries, and it's probably in every country. It's just that certain countries haven't actually reported it. So as a healthcare scientist, we have done a huge amount for the outbreak. So this is a picture of two scientists at Great Ormond Street where I work, carrying out what we call PCR, which is polymerase chain reaction. So this is a test where we look for the virus in someone's nose and throat. So you have a swab taken from the very back of your nose. It is particularly nasty. And we see whether or not you've got the virus in your nose and throat. At Great Ormond Street, we've been running 1,000. We have the capacity to run 1,000 of these every day. And we were covering all of North Central London. We're also running antibody testing. So there's an awful lot flying around about the antibodies. There is having a positive antibody test suggests that you have probably been infected with COVID-19 in the recent past. But what it doesn't do is it doesn't tell you that you are immune. It might mean you're immune, but we don't know that yet. Because this is a respiratory virus, we have respiratory physiologists who have been doing an awful lot of work on respiratory tests and supporting lung function in people who've been infected. So a lot of people who've been infected with coronavirus, and this is about 1 in 5 people who catch coronavirus, no matter what age they are, end up with fairly serious lung disease and are not fully recovered even after a couple of months. And then we have our engineers who are designing ventilators and doing a lot of work that way. And we also have our cardiac physiologists who have been a major part because we've now found that there's a lot of response from the cardiovascular system and people's hearts, and we need to protect them. So the important things to remember with COVID is by far the best ways of keeping yourself safe is hand hygiene. It sounds boring and it's not fun and sexy, but it is by far the best way of keeping yourself safe. 1 in 5 respiratory infections are stopped by people washing their hands. It's that easy. And social distancing. So be very careful when you're out and try not to spend time with other people who you don't live with in very close spaces. Okay. I'm going to try and stop screen sharing. Okay, so I have rattled on inanely for a while. Does anyone have any questions?
If you've got questions, just put it on the chat function, guys.
Okay, so the main difference between public and private sectors of healthcare. So the first major difference is that there is no emergency care in private healthcare. So you can have the fanciest private healthcare there is, but if you need an emergency to go to A&E, you will have to go through the NHS. Everything else, a large portion of it goes through the NHS anyway. So there are now a handful of private labs, so private laboratories where the blood tests and things that you have will go through the hospital itself, but most of it comes through NHS labs. And most private patients, a lot of private patients are seen within NHS buildings. So there's not a huge difference. The main thing as a patient that you get is that you can sort of guarantee seeing the same doctor in a way that you can't in public healthcare. And obviously that you pay for it. Yeah, nice one. So Research. So we do certain bits of research through a huge amount of research is actually publicly funded. So we do a lot of people do research on the side. So because I'm a scientist, we do a lot of research anyway. So it's part of our job description. So I am part of a project in which we are looking at reducing childhood mortality in Mali, in West Africa, by 20% by prescribing azithromycin 3 times for children under the age of 2 to see whether or not that's because it seems to reduce childhood mortality by reducing infectious disease. That particular study is funded by the Gates Foundation, which is a private funding body. But the mini research project that I was doing today, which was looking at whether or not we can reuse surgical masks, was funded by NHS England. And generally you have large research funding bodies, and once you are established within your career within the health service, you would then look for funding and you would apply for funding bodies. The big one of those is the National Institute of Health Research, or the NIHR, and the Wellcome Trust, which is based at Houston. It's all right. So the one thing I would say is that another one of the things about healthcare science is that it is relatively easy to balance a diagnostic career and a research career. So I know a lot of people who apply to funding bodies, so private funding bodies, and they get part of their day-to-day role backfilled. So I've applied to the NIHR, the National Institute of Health Research, to pay 3 days a week of my salary, which means that for 4 years, I could spend 3 days a week doing research, but 2 days a week still doing my day-to-day diagnostic job, which means I don't lose out by just leaving the NHS altogether. So I can carry on with my clinical career and not lose those skills, which is really important to me. And I get a say on who I employ, which is even better. So it depends on when you go into it. So when I left school, I did 6 months. I did a training course that gave me 6 months in each of the major life science disciplines. So I did 6 months of microbiology, 6 months of histopathology, which is tissue samples, 6 months of hematology and biochemistry and immunology. And then I chose to specialize in immunology. So I specialized when I was 20. Normally, once you've done the degree and you start, you will apply to one particular department. But there's nothing to say you can't switch later. The longer you've been in a career, the less likely you are to switch. If you have a PhD in a subject, it's difficult to move, but it's not. I've known people do it. It does take a long time to get to the top, though. So my line manager, for example, did a slightly weird route. So she has an undergraduate degree in zoology, and then a master's in biophysics, and then another master's in clinical microbiology. And she is now, so hopefully in the next couple of weeks, we will find that she is consultant of infection. But that process from starting microbiology to getting the consultant qualifications was 8 years. So has anyone got anything else, or? Alright, so there's a few differences. So there's they are different. They're different work streams. There is sometimes held misbelief that diagnostics is less important than research, but it's something I will constantly challenge, because you can be the best researcher in the world and you can come up with the best, you can come up with the best tests that there are, but unless you've got diagnostic services that will go through and they will run those tests every single day, what is the point in coming up with it? You may have, it's been all over the news, the number of diagnostic tests that have been done for COVID-19, and that there have been problems and teething issues getting all of those laboratories up to scratch. It's a huge amount of work. So at Great Ormond Street, we went from not being able to run, having never heard of the virus, to there being declared a pandemic. So the pandemic was declared on the 11th of March. Within 3 weeks, we had the equipment, the reagents, the testing in process to run 1,000 samples a day. It was a huge piece of work, but we did really well. I like diagnostics because you can do a lot of throughput and you can help a lot of people. I know that when I was working in immunology and we would do a particular test called double-stranded DNA antibodies, which is an antibody that is present in lupus patients when they're having a relapse. So for something like lupus, you never get better. You just have points where you're ill and points where you're not ill. And I used to be able to test for that, and I would be able to tell the doctor when they were improving and when they needed treatments again. And that meant I could have quite a strong impact on that patient's life, even though they have no idea who I am. And we used to have the same patients in over and over again. So I used to know their names. And that meant you could do little things. If I had a patient come in who I knew was likely to have very high antibody levels, I would test them, but I would also automatically put them through for the second level of tests. And I would do it multiple times because I knew it would need doing anyway. So I could speed up the process for that patient. We then had other bits. So I worked in a big lab where we did HIV. So we did HIV testing, but we did everything. So we did the screen. So if you're testing someone for HIV, you will look for HIV antibodies in their blood. So we did that. We did the confirmation testing, because you will never give an HIV diagnosis based on one sample, because it's such a big diagnosis and has such a large impact on someone's life. You will always have it twice, just to make sure that you are giving someone the right information. We would then do genotyping. So that means we would take the HIV and we would map out exactly what it looked like on a molecular level, give that to the doctors so they could use that to develop a treatment plan. And then we would look at the white blood cell counts of the patients. So we did the entire treatment pathway within one department, which I really liked. Research-wise, you could have a massive impact. You could change the world, stand up and gain your Nobel Prize. But your chances of making that much of an impact are lower. There's pros and cons to both. But what I would do as well is that the nicer thing about diagnostics is it's a little bit more repetitive, but it is also reliable. So you can go into work, and I used to be able to go into work and know that I would test 800 patients and give them a result in one day. Whereas if you go into research, you can spend weeks and weeks and weeks doing one test to discover that it all failed horribly and you've achieved nothing with your last month. So there's pros and cons. I suppose if I have a question for all of you then, I'm afraid I don't actually know what year group you all are, but if you're looking at university, have you thought about what you might want to do and what subjects you're looking at? I'm throwing my own now.
So they're all year 12, Vicky.
Okay.
So they be applying for university next term.
Ah. So has everyone worked out what they want to do? Obviously, it's a changing world. Yay. Highly approved. Although what I would say, if you're going to go and do biomedical science, and I have a biomedical science degree. Oh, cool. So if you do biomedical sciences, I would make sure you find a degree that is accredited by the Institute of Biomedical Science. I put vacancies out and I have hundreds, and I mean hundreds of applicants who do a biomedical science degree at say Manchester University or Durham or York or whatever, somewhere like that, and it's not accredited and I can't give them a job. So if you want to be a biomedical scientist within the NHS, you need to do a degree that is accredited by the Institute of Biomedical Science. If you want to do a biomedical sciences degree to go into something else, then you don't need it. But I would always recommend doing one that would give you the flexibility to do both. Healthcare professions are going to become incredibly competitive in the next few years because we are heading into a global recession if we're not there already, and healthcare is a guaranteed employment stream. Medicine, always fun. So research-based degrees, so you can do pretty much anything for that one. But I would look for things, personally, if I was doing a science degree, and I say this as someone who had no choice over their degree, I got a job and I was told where I was going and when I was going and which options I was taking. But I would always only pick a science degree that had a research project, not a dissertation. If I am employing, I don't hire people with dissertations. You have no lab skills whatsoever. And I very much sympathize with you guys. So I finished school in 2006. And in 2008, we headed into a global financial recession. And at that point, job competitiveness absolutely skyrocketed. I went for a training program. There were 10,000 applicants for 200 jobs. If I put out an entry-level job, I will have 250 applicants in 24 hours. It's terrifying. So it's anything you can do to bump up your application and get yourself up the ladder is really important. And so for something like, what you want is experience. Any way that you can get experience in your chosen field, go out and get it. Because it will immediately put you above large portions of the people you're competing with for jobs. So private research is one way of doing it, but you will also not. One of the things that really put me off private research is it pays abysmally badly. So I finished these figures are 14 years old, but I did a 4-year training course in the NHS, which got me my undergraduate degree. So at age 18, straight out of school, I was earning £15,000 a year, and I was going, and then I was paid, and I got my degree out of that. So they paid all of my university fees, and I only went to work 4 days a week, and I spent 1 day a week at university. When I finished, and we were in the middle of a global recession, so my contract wasn't renewed, I looked at private research assistant posts, and they were paying £13,000 a year, but you had to be a graduate. So I would have actually lost £2,000 or £3,000 a year for a research assistant post. They're not as bad as that now, partially because that's now significantly below minimum wage. But research assistant posts are low. And in order to get far enough in research, you will need a PhD. And PhD stipends are not high. And at the moment, if we fall into a recession, the number of PhDs available will drop. Or if you're lucky enough, if you are fortunate enough that you can self-fund, that's brilliant. But very few people are fortunate enough to be in that position. Particularly as that would mean not being able to do paid work for 3 or 4 years. Very, very few people will actually get their PhD in under 3 years. I have one friend who did it in 2 years and 11 months because she absolutely refused to work for free. But that's unusual. Most people take at least 4. So I guess one of the other things to think about is if you're at university, and one of the best ways that I've seen people get in to the job market, and this to be honest goes beyond just my sector. This goes through all jobs. Firstly, you want to think outside the box a little bit. So I got my job because I was 17. I was beginning of year 13, and I didn't want to go to university. Not interested at all. So but I didn't want to do any of the jobs that people said that you could do without a degree. So I found an application form for a biomedical scientist job, and I phoned up the lab and said, look, I'm 17, so I can't apply for this job, but can I come and see what you do? And they let me spend a week in their lab, and 6 weeks later, they sent me an application form for a 4-year training course. So there's always the opportunity to do that. Reach out, see what you can do. Another good one is while you're at university, go to your local hospital, see if you can sign up on their bank. So they have bank staff. So you're not guaranteed any work. You have no contracted hours, but you can sign up for shifts. And so you can do lab assistant work. And even if you don't want to go into hospital lab work at the end, you've still got several years experience of working Saturdays in a lab, which first of all pays, which is always good because university is now horrifically expensive, and gives you that work experience. And it's one of those when you start looking through, when employers are going through, if someone's got to shortlist hundreds and hundreds of application forms, and they are going to look for reasons to cut. I have a friend who works in recruitment, and she's just put a job out, not in the NHS. She has 750 applicants, and she has to read every single application form. By the time you get to that, people are looking for reasons not to employ you, because they're just going to look for any way of getting that 750 down to 5 or 6. And you then want to do everything you can to stand out, to be positive. And it's not fun. And I am very lucky. I am aware that I'm very lucky that I have been on short-term contracts for the last 4 years, and I managed to secure a permanent job in December in an industry that is not going to self-implode. But have a look. Any experience you can get, any contacts that you can get will always benefit you longer term, because the other thing they will do is that they will prioritize people they already know. Because if you have someone who already works in your lab 2 days a week, you know that they are, you know what kind of work you'll get out of them, and they're a safer bet than someone randomly off a piece of paper.
Larissa or Santoshi, do you have any questions? What is it you're looking to go into at university?
No. Yeah, I suppose the other big thing, and this is career advice, you know, not within my sector, although obviously I love my sector, which is why I come and do talks on it and have spent 15 years of my life doing it. But don't just look at subjects that you like, but look at skills that you have, things that you are good at. What are you good at? And everyone's got things they're good at in their day-to-day life. And find a job. Try and find a job that matches the two, because then you can find something that you will actually vaguely enjoy. You're going to spend 40 hours a week for 30, 40 years in whatever career you end up doing. Make sure it's something that you actually want to do. I'm lucky. I like my job. It doesn't pay well, and I currently work 80 hours a week, but it is a job I enjoy, and that's why I keep going. And that is actually the advantage of if you can go and do work experience, and not just work experience in the sense of, you know, school provided work experience, which I know you haven't been able to do this year, but my old school didn't do it at all. So it doesn't necessarily matter. But if you can go and see the kind of job you want to do and do it, even if it's for a few weeks, and if you do it at over 18, you're more likely to be able to actually do things, then you can decide whether or not it's what you want to do and something that you think you'll actually enjoy, or at least not hate.
I think that might be it, Vicky. I don't think anybody's got any more questions, looks like.
That's fine. If anyone does, you can always ask through your teachers, and I can respond that way if you ever think of anything afterwards. I'm around.
Thank you very much for that, Vicky.
It's all right.
Lots of very useful information. Thank you.
You're welcome. I hope it helped. Anyway.
Thank you. All right.
And good luck, everyone.
Thank you. Thanks. Bye-bye.
Bye.